Next question. Which of the following statement on the microalbuminuria is not true? First option, cannot be detected by routine laboratory tests. Urine protein less than 32 to 99 micrograms per day is called microalbuminuria. Third option, microalbuminuria is an independent risk factor for cardiovascular risk in diabetic patients. And fourth option, microalbuminuria is the earliest marker of the diabetic nephropathy. So if you see the point given is which of the following is not true. So please remember, microalbuminuria, it can be detected by the routine laboratory test, that is urine albumin examination. Second important, when do we use this term microalbuminuria? We use this term microalbuminuria when the quantity of albumin is 30 to 300 milligrams per 24 hours. Okay, so it is not micrograms per day, it should be milligrams per 24 hours. And microalbuminuria is an independent risk factor for cardiovascular risk in diabetic patients. Yes, that is a true statement. And microalbuminuria is the earliest marker of the diabetic nephropathy. Yes, even that is also a true statement. Okay, so right, which is not true or which is the false statement? That is B, that is 32 to 99 micrograms per day is called microalbuminuria is an incorrect or the wrong statement, right? Next question. And please remember, in diabetic nephropathy, one of the earliest manifestation that can be seen is microalbuminuria. And what is the drug of choice for the microalbuminuria? The drug of choice for microalbuminuria is the ACE inhibitors. Now, what these particular ACE inhibitors will do? These ACE inhibitors will reduce the intraglomerular pressure. Right, these ACE inhibitors will reduce the intraglomerular pressure. So by reducing the intraglomerular pressure, the proteinuria decreases. Right, by reducing the intraglomerular pressure, the proteinuria decreases. So the answer here is B. Next question. All of the following may result in polyuria except chronic renal failure, hypoadrenalism, hypercalcemia, lithium carbonate therapy. So in patients with chronic renal failure, they will have oliguria first, and followed by that there will be anuria. Now, what is the definition of the oliguria? Definition of oliguria is the quantity of the urine output will be less than 400 ml per 24 hours, whereas anuria is that where the quantity of the urine output will be less than 100 ml, right, less than 100 ml per 24 hours. That is what is called as the anuria. Whereas you take in case of the hypoadrenalism, the aldosterone deficiency will be there, and that will cause the impairment of sodium and water retention, and that will result in the polyuria. And in patients with hypercalcemia, these patients will develop what is called as nephrogenic diabetes insipidus. Right, these patients will develop nephrogenic diabetes insipidus. And secondly to this nephrogenic diabetes insipidus, these patients will have the polyuria. And lithium carbonate therapy. Lithium intoxication is also another important drug which will make the individual to develop the nephrogenic diabetes insipidus. So please remember, in case of BCD option, you will have polyuria, but in case of chronic renal failure, you will have oliguria or the anuria will be there. Next question. Regarding adult polycystic kidney disease, which of the following statement is not correct? Okay, first option is inherited as autosomal dominant with 100% penetrance, often associated with the hepatic cyst, associated with increased incidence of subarachnoid hemorrhage, renal cell carcinoma is a frequent association. Now, if you take this polycystic kidney disease, this is inherited in two forms. One is autosomal dominant and as well as the autosomal recessive type of inheritance. Autosomal dominant type of inheritance is what is observed in adults. Autosomal recessive type of inheritance is what is observed in children. Alright, and if you take the autosomal dominant type of inheritance which is seen in adults or which is observed in adults, it is mainly due to gene mutation, right? And what is the gene that is being mutated? The gene that is being mutated is the PKD1 and as well as the PKD2 gene. And PKD1 gene, it is present on chromosome 16, and PKD2 gene, it is present on the chromosome 4. And you take in case of the children, in case of children, the type of inheritance is autosomal recessive type of inheritance, and the gene that is being mutated is PKHD1. This is the gene that is being mutated, right? And this PKHD1 gene, it is present on the chromosome 6, right? This is present on the chromosome 6. And this polycystic kidney disease patients, that is ADPKD, these patients, they have increased risk of the hypertension. And these patients with polycystic kidney disease, please remember, the cysts are also present outside the kidney. So what are the other sites where the cysts can be present? The cysts can also be present in the liver. Hepatic cysts can also be present. And in these patients with autosomal dominant type of polycystic kidney disease, you have the CNS manifestations. Now, what will be the CNS manifestations? That is rupture of berry aneurysm, and that will result in the subarachnoid hemorrhage. These will be the CNS manifestations. And cardiovascular manifestations will be in the form of the mitral valve prolapse, right? And the next important is, these patients will also have the gastrointestinal tract manifestations, and the gastrointestinal tract manifestations, that will be in the form of the polyps within the GIT, right? That will be in the form of polyps within the GIT. Okay, so autosomal dominant type of polycystic kidney disease, please remember, they also have the extrarenal manifestations, and they also have extrarenal cysts as well. And this autosomal dominant type of polycystic kidney disease, it is inherited with 100% penetrance. So the incorrect statement here is renal cell carcinoma is a frequent association, is an incorrect statement. And how will you diagnose this polycystic kidney disease? That is by doing ultrasound of the abdomen, but the confirmatory diagnosis can be done by the CT of the abdomen, right? And most of these patients with autosomal dominant type of polycystic kidney disease, they remain asymptomatic by almost up to 3rd to 4th decade. They remain asymptomatic. Once they develop the symptoms, these symptoms, they include the development of the loin pain, right? They include the development of the loin pain. And one more important symptom that you will have in patients with polycystic kidney disease is these patients, they can have the hematuria. So once these particular cysts are infected, the patient will also have acute abdominal pain, right? These patients will also have acute abdominal pain when the cysts are being infected. And one more important point that you need to remember is these patients, by 6th decade, they go into a state of end-stage renal disease. They go into a state of end-stage renal disease by 6th decade, right? So this is about your polycystic kidney disease. Next question. Which of the following is not a feature of the chronic renal failure? Hyperparathyroidism, osteomalacia, hyperthyroidism, decreased vitamin D levels. So in patients with chronic renal failure, there will be hyperparathyroidism. Why? Because in patients with chronic renal failure, they will have hypocalcemia, and it is the hypocalcemia which will trigger the parathormone secretion. That is, these patients will have secondary hyperparathyroidism. And because of the vitamin D deficiency level, these patients will also have osteomalacia. These patients will have osteomalacia because of decrease in the vitamin D levels, right? And in patients with chronic renal failure, they will not have hyperthyroidism, right? And you should know, for chronic renal failure, what is the most common cause of chronic renal failure? Most common cause of chronic renal failure is diabetes mellitus, and renal vascular pathologies which can cause chronic renal failure is renal artery stenosis, and you need to know the obstructive pathologies that will be causing chronic renal failure, that is benign prostatic hyperplasia. So benign prostatic hyperplasia, actually it will cause postrenal type of acute kidney injury. But if this benign prostatic hyperplasia is being neglected for a longer duration of time, the acute kidney injury can progress to the development of the chronic renal failure as well. So these are the etiologies in CRF. And if you take the electrolyte abnormalities in case of chronic renal failure, these patients will have hyperkalemia, these patients will have the hyperphosphatemia, these patients will have the hypermagnesemia, these patients will have increase in the uric acid levels, these patients will have increase in the blood urea nitrogen levels, these patients will have increase in the serum creatinine levels. So these will be the metabolic abnormalities where they are increased. And see, why they are increased? All these substances, they have to be excreted through the kidney. But whenever there is a renal impairment, these substances, they are not excreted out, right? And if you take the sodium levels, they are being reduced. So there will be dilutional hyponatremia. There will be dilutional hyponatremia, and the calcium levels will be reduced. Why calcium level will be reduced? That is because of vitamin D deficiency. There will be hypocalcemia in these patients, and in response to your hypocalcemia, there will be increase in parathormone secretion, and that we call it as the hyperparathyroidism. That we call it as hyperparathyroidism. And in patients with chronic renal failure, right, you will be able to assess the severity by the GFR. Now, based on the GFR, how much is the normal GFR value? That is 90 to 120 ml per minute per 1.73 meter square. That is a normal GFR. And in stage 1, how much will be the GFR? In stage 1, the GFR, it is like more than 90. Whereas in stage 2, the GFR is reduced by almost 30 times. That is 60 to 89. Whereas in stage 3, if you take the GFR, that will be around 30 to 59, whereas in stage 4 the GFR will be 15 to 29, and in stage 5 the GFR will be less than 15. So this will be the GFR in patients with the chronic renal failure. Now, how will you estimate the GFR? So please remember, we need to use cystatin based formulas, right? We need to use the cystatin based formulas for assessment of the glomerular filtration rate. This is very, very important. Cystatin based formulas, they are not influenced by the muscle mass of the individual, right? So this is about the chronic renal failure. And when the individual goes into GFR less than 15, that we call it as the end stage renal disease, right? And once the individual develops the end stage renal disease, please remember one important point: they will be requiring renal replacement therapy, right? And what is the form of the renal replacement therapy that we have? The option is, one is dialysis. This is one option of the renal replacement therapy. And another important option of the renal replacement therapy, that will be in the form of the kidney transplantation. That will be in the form of kidney transplantation. And if you take the dialysis, we have two forms of dialysis. One is hemodialysis and the other one is the peritoneal dialysis. These are the two forms of dialysis. And the kidney transplantation, the preferable kidney is allogenic kidney transplantation has to be done, right? That is from the same family member, preferably the first degree relative is what is being preferred, right? So this is about the discussion related to chronic renal failure. Now, patient on insulin in CKD stage 4, what is the dose adjustment the insulin is required? Increased insulin, decreased insulin, normal insulin, you need to add DPP4 inhibitor. Now, when there is, if you take insulin, it is the hormone that is metabolized and excreted through the kidney, right? Excreted through the kidney, right? Now, whenever there is renal impairment, the insulin is not excreted out and there will be increase in the insulin level in the body whenever there is development of chronic renal failure. So what you have to do, an important point here is, whenever there is a chronic renal failure, you need to reduce the dose of the injected insulin because the insulin is not getting excreted out. So the half-life of the insulin increases when there is renal impairment. So you need to decrease the dose of the insulin. So you need to give only 80% of the calculated dose. Right? You need to give 80% of the calculated dose. So you need to decrease the insulin. It is not you need to increase or you need to give normal insulin, right? And DPP4 inhibitors are given in the treatment of type 2 diabetes mellitus. And in renal failure, the gliptin or DPP4 inhibitor that can be given is linagliptin, right? Because linagliptin, it is metabolized in the liver, right? Whereas the remaining all gliptins, they are metabolized in the kidney and excreted through the kidney, like you take saxagliptin or you take vildagliptin, right? All these are metabolized in the kidney and excreted through the kidney. So you cannot give this vildagliptin or saxagliptin, but if at all, if you want to give a gliptin in case of renal failure, what you can give is linagliptin, right? And regarding the dosage of the insulin, you need to decrease the dosage of the insulin, right? Next question. True about the light microscopy changes in the minimal change disease. The options are no abnormality observed, fusion of the food process, absence of the immunoglobulin, absence of the complement. So the question asked is in the light microscopy. The question asked is light microscopy. Now, if you take minimal change disease, it is a form of nephrotic syndrome, right? It is a form of nephrotic syndrome, right? And in case of nephrotic syndrome, the most common cause of nephrotic syndrome in children, right? Most common cause of nephrotic syndrome in children, that is minimal change disease. That is minimal change disease, all right? And the next very important point is these patients with minimal change disease, they have, right, they have selective proteinuria. They have selective proteinuria. And what is that protein that is being excreted out? That is albumin that is being excreted out. Okay, you will have selective proteinuria where albumin is being excreted out. So albumin is the one which will contribute to the oncotic pressure within the vessel. So once the albumin is out, the oncotic pressure will be reduced. So once the oncotic pressure is reduced, the fluid from the vascular compartment will enter into the extravascular compartment. So please remember, these patients, whenever they get up, they will have edema in the face, right? And as the time progresses, they will have the ascites. They will also develop pedal edema. So that will be the presentation in patients with the minimal change disease. And in minimal change disease, you have to remember that the investigation of choice, or in fact in any form of the nephrotic syndrome, the investigation of choice is the renal biopsy. And whenever you do renal biopsy, you have to observe that under the light microscopy, electron microscopy and fluorescent microscopy. What you need to know is, in light microscopy, in case of minimal change disease, there is no abnormality observed. There is no abnormality observed. Whereas the fusion of the food process will be there, but it is not observed under the light microscopy. And absence of the immunoglobulins, that you don't see in case of the light microscopy, right? In order to check for the immunoglobulins, you need to do a fluorescent microscopy. And even the absence of complement, yes, absence of complement will be there in case of the minimal change disease, but you have to observe that under the fluorescent microscopy, but not the light microscopy. So the answer is no abnormality is observed under the light microscopy in case of the minimal change disease, right? And next question, a child presents with hematuria and nephrotic syndrome. A diagnosis of minimal change disease was made. Which of the following statements about the diagnosis is true? Glomerular function is lost due to loss of polyanions around the food process. Food process of the podocytes in the glomerular membrane are normal. Third, glomerular function is lost due to deposition of IgA on the glomerular membrane. Focal segmental changes are observed. So a very important point that you need to understand here is minimal change disease, usually they will have proteinuria and thereby they will have the foamy urine. And in case of minimal change disease, usually you don't have hematuria, right? 90% of patients with minimal change disease, hematuria is absent. It is only 10% of individuals there can be presence of the hematuria. And hematuria is actually the feature of the nephritic syndrome rather than nephrotic syndrome. So if you see the differences between the nephrotic and as well as the nephritic syndrome, in nephrotic syndrome, the quantity of the proteinuria is more than 3.5 grams per 24 hours. Whereas in nephritic syndrome, the quantity of the proteinuria is around 3 grams per 24 hours. And in case of nephrotic syndrome, you have significant albuminuria, right? So these patients will have hypoalbuminemia, right? And because of hypoalbuminemia, these patients will develop edema, right? Because of hypoalbuminemia, these patients will have edema. And next to that, these patients will have the hypercoagulability, right? And these patients will have the hyperlipidemia, right? And these patients will have lipiduria. Whereas in case of nephrotic syndrome, hematuria may or may not be present, right? It may or may not be present. We have only one form of nephrotic syndrome where definite hematuria that will be there is focal segmental glomerulosclerosis. Hematuria will be present. Whereas in other forms of nephrotic syndrome, the hematuria, it is rare or completely absent. Whereas in nephritic syndrome, the proteinuria will be around 3 grams or less than 3 grams per 24 hours. And in case of nephritic syndrome, they will definitely have the hematuria. And when you do a urine examination also, the urine examination will show the presence of the proteins. Urine examination will show the presence of the RBC and as well as the RBC CAS. And the urine examination will also show the presence of the WBC as well as WBC CAS. right? That is what in case of the nephritic syndrome. Okay, so now if you see this question of nephrotic syndrome, in nephrotic syndrome, hematuria, that is rare entity, and that too in minimal change disease, it is observed only in 10% of patients. Now, glomerular function is lost due to loss of polyanion around the food process. That is a correct statement, and that is a true statement. And due to loss of this polyanion around the food processes, right, you will observe that there is fusion of the food processes. And the fusion of the food process can be observed on the electron microscopy. Can be observed on electron microscopy, but not on the light microscopy. And what is the polyanion that is being lost? The polyanion that is being lost is heparan sulfate proteoglycan. Right, heparan sulfate proteoglycan, that is being lost, which is present on the food process, and that is the reason why there will be fusion of the food process. And food process of the podocytes in the glomerular function, right, are normal. That is a wrong statement. And glomerular function is lost due to the deposition of the IgA on the glomerular membrane? No. The deposition of the IgA in the glomerular membrane, it is observed in patients with IgA nephropathy. Okay, so in patients with IgA nephropathy, you have the IgA being deposited within the glomerular membrane, and this particular IgA nephropathy, it is called as Berger's disease, right? This is called Berger's disease, and these patients with IgA nephropathy, they have nephritic syndrome, right? They have nephritic syndrome in case of the IgA nephropathy. All right, and in case of IgA nephropathy, the clinical manifestation will be in the form of recurrent hematuria, right? That will be in the form of recurrent hematuria, and that too it will be recurrent gross hematuria will be there. Okay, and the next important point is the focal segmental changes are observed. Focal segmental changes are observed in patients with focal segmental glomerulosclerosis, which is a form of nephrotic syndrome, but it is not observed in case of minimal change disease. So the correct answer here is the glomerular function is lost due to loss of polyanions around the food process is a true statement in patients with the minimal change disease, right? Next question. All are steroid resistant except post-streptococcal glomerulonephritis, minimal change disease, rapidly progressive glomerulonephritis, and recurrent hematuria. Post-streptococcal glomerulonephritis, these patients, they don't respond to steroids. There is no role of steroids in case of the post-streptococcal glomerulonephritis. Whereas in case of minimal change disease, the drug of choice is steroids. Right, the drug of choice is steroids. Okay, and you have to give steroids for nearly around 24 weeks, right? Or some patients, they require just only 8 weeks, but some patients, they require up to 24 weeks also, right? And we have a terminology called steroid dependent nephrotic syndrome. Steroid dependent nephrotic syndrome is that you give steroids, right? We need to give the steroids, and once you stop the steroids, right, once you stop the steroids, the individual can go into a state of relapse. Right, the individual can have a relapse once you stop the steroids, and that is what is called as the steroid dependent nephrotic syndrome. So in these patients, like what you need to give is, you need to give a prolonged period of the steroids, and whenever you are giving steroids for a longer time, these patients can develop the Cushing syndrome. So how can you avoid this Cushing's is, the alternative immunosuppressants that you can give is, you can give cyclophosphamide, right, cyclophosphamide. Okay, and in rapidly progressive glomerulonephritis, plus minus the requirement of the steroids, and recurrent hematuria, right, they are like we don't give the steroids in case of the recurrent hematuria. Okay, and because see, one of the condition where you have recurrent hematuria is like IgA nephropathy, but in case of the IgA nephropathy, please remember they will be requiring the steroids, and as well as they require the other immunosuppressants like azathioprine. Okay, so all are steroid resistant except that is minimal change disease where they respond to your steroids, right? Next, which of the following drug is not a part of the triple therapy immunosuppressive therapy for the post-renal transplant patients? Now, so I said you that in end-stage renal disease, you will be doing renal replacement therapy, and that renal replacement therapy either is in the form of dialysis or in the form of the kidney transplantation. And the kidney transplantation that you need to do is allogenic kidney transplantation should be done. right, allogenic kidney transplantation should be done in case of the end-stage renal disease. And this allogenic kidney transplantation is the one where the kidney is being taken from the first degree relative. And which particular kidney of the donor has to be taken? It is the left kidney of the donor. Right, it is the left kidney of the donor has to be taken, and that has to be placed in the right iliac fossa. Right, that has to be placed in the right iliac fossa. That is very, very important. And once you place the kidney in the right iliac fossa, immediately what can happen is there will be the immune rejection. So what are the drugs that you need to give is you need to give this particular cap. What is this cap? That is cyclosporin, then azathioprine, and then the prednisolone. So these drugs, right, these drugs, they have to be given mainly to suppress the immunity in the recipient. If you can't suppress the immunity, or if you don't suppress the immunity, there will be immune rejection to the kidney. So that is the reason why you need to give cyclosporin, azathioprine, and as well as the prednisolone, right? Which is not the part of the triple therapy is your FK506. And the next point is, whenever you have done the renal replacement therapy or the kidney transplantation, what is very, very important? You need to look for the blood grouping, and you need to check for the HLA matching. The gene for HLA matching, it is present on the chromosome 6. Right, it is present on chromosome 6. Whereas the gene for the blood grouping, that is present on the chromosome 9. Right, so these two are mandatory. You should definitely do these two in order to do the kidney transplantation, both in the donor and as well as the recipient. And in the donor, what are the investigations that you need to do is, in the donor, you need to check for the blood transmissible infections. So what will be that? That is your viral infections you need to check for, right? What will be that viral infections that you need to check for? The HIV, hepatitis B virus, and as well as the hepatitis C virus, right? And these viral infections you need to check because they can be transmitted. And you also need to do a Doppler, renal artery Doppler in the donor to rule out the renal artery stenosis. Okay, and within the recipient you need to do blood grouping and as well as HLA matching in order to see that whether the donor kidney is being suitable for the patient or not, right? So this is about the renal replacement therapy. And once you have done renal replacement, kidney transplantation, to the recipient what you need to give, cyclosporin, azathioprine, and prednisolone should be given to prevent the immune rejection, right? Next question. Most common nephropathy associated with the malignancy: membranous nephropathy, minimal change disease, IgA nephropathy, focal segmental glomerulosclerosis. It is membranous nephropathy that can be associated with, or membranous glomerulonephritis that can be associated with the tumors of the colon, that can be associated with the tumors of the lung, that can be associated with the hematological malignancies such as the chronic lymphocytic leukemia, right? Hematological malignancies like chronic lymphocytic leukemia. Whereas minimal change disease, if you observe, right? Minimal change disease, if you observe, it is not associated with the malignancy. Minimal change disease, it is associated with certain drugs, that is D-penicillamine, right? And this particular minimal change disease, I said you already, it is commonly seen in children. Whereas membranous glomerulonephritis, this is very commonly observed in the elderly individuals, right? This is very commonly observed in elderly individuals. Whereas, which is also a form of membranous glomerulonephritis is what? It is a form of nephrotic syndrome, which is commonly observed in the elderly individuals. Whereas focal segmental glomerulosclerosis, this is also a form of nephrotic syndrome, which is commonly observed in the adults, right? Which is commonly observed in adults. Whereas IgA nephropathy, it is a form of the nephritic syndrome, and IgA nephropathy will occur 2 to 4 days after the upper respiratory tract infection, right? This will occur 2 to 4 days after the upper respiratory tract infection. So that is what is your IgA nephropathy. Whereas focal segmental glomerulosclerosis, we have two forms, primary and as well as secondary focal segmental glomerulosclerosis. Primary focal segmental glomerulosclerosis, it is due to gene mutation, right? It is due to gene mutation. Whereas secondary focal segmental glomerulosclerosis, it is secondary to certain drugs like bisphosphonates, it can be secondary to HIV infection, it can be secondary to obesity, and it can also be secondary to certain genetic disorders, that is the Alport syndrome. Okay, so the one which is associated with the malignancy is the membranous glomerulonephritis, which is a form of nephrotic syndrome commonly observed in the elderly individuals, right? Next question. A 10-year-old child presents with edema and decreased urine output. On evaluation, serum albumin is 2.5 grams per deciliter and the serum creatinine is 0.5 milligrams per deciliter. Urine protein, it is 3 plus with no RBC cast. Pathological change expected is, so what all you are having, there is 10-year child, decrease in urine output, hypoalbuminemia is there, and urine 3 plus, protein 3 plus and no RBC cast. So children with hypoalbuminemia causing edema with urine 3 plus, suggestive of the minimal change disease, right? This is the classical picture that you see in patients with nephrotic syndrome in children. Now, regarding the proteinuria, this is a very important question. So this 3 plus, how is that you are able to make out? That is by your dipstick, right? So dipstick detection of the proteinuria, if you observe, for example, if the dipstick test says it is like only a trace protein, then the quantity of the proteinuria is 5 to 20 milligrams per deciliter. And if the dipstick test shows 1 plus protein, then the quantity of the protein, it is around 30 milligrams per deciliter. And if the dipstick test shows 2 plus protein, then the quantity of the proteinuria is around 100 milligrams per deciliter. And if the dipstick test shows 3 plus proteinuria, then the quantity of the proteinuria is around 300 milligrams per deciliter. And if the dipstick test shows 4 plus proteinuria, then the quantity of the protein is more than 2 grams per deciliter, right? So dipstick detection of the proteinuria is being done in the following manner. Whereas you take interstitial nephritis. Interstitial nephritis is the one where the individual will develop what is called as the acute kidney injury, right? Interstitial nephritis, it is an acute variety. And what will be the presentation in interstitial nephritis? There will be presence of fever. There can also be presence of rash, right? And the eosinophil levels, they are increased in case of the interstitial nephritis. And these patients will have oliguric renal failure, right? And this will develop, which one? The interstitial nephritis will develop 7 to 10 days of treatment with methicillin or another beta-lactam antibiotic. Whereas IgA nephropathy, already I have said, it occurs 2 to 4 days after the upper respiratory tract infection. And these patients with IgA nephropathy, they'll have gross hematuria. They'll have gross hematuria. Then you take focal segmental glomerulosclerosis. It is a variety of nephrotic syndrome in adults, and these patients with FSGS, they will have hematuria. They'll have hematuria, right? But here it says that there is no RBC cast, and that too in children. So that will rule out your focal segmental glomerulosclerosis. And in case of focal segmental glomerulosclerosis, as the word itself tells you, focal segmental glomerulosclerosis. So it is not all the glomeruli which are being affected, that is first point. And it is not the entire glomerulus which will undergo sclerosis. That is why it is called focal segmental glomerulosclerosis, okay? And the next important point in case of the focal segmental glomerulosclerosis is that in case of FSGS, right? In case of FSGS, please remember that when you do a biopsy, you have to do biopsy from the deeper portions of the kidney, because the lesions will be there at the corticomedullary junction. That is the reason why you need to take the biopsy from the deeper portions of the kidney, right? And when you do a biopsy also, under the light microscopy, you will see that it is only the part of the glomerulus which will undergo the sclerosis, right? Whereas electron microscopy will show you the presence of mesangial and as well as the paramesangial deposits will be there. Right, mesangial and paramesangial deposits will be there in electron microscopy in patients with focal segmental glomerulosclerosis, right? Now, next question. All of the following is true about the glomerular proteinuria except diabetes mellitus, amyloidosis, multiple myeloma, ACE inhibitors decreases the proteinuria. So, glomerular proteinuria, diabetes mellitus, yes, glomerular proteinuria. Amyloidosis, yes, glomerular proteinuria. ACE inhibitors will decrease the proteinuria, that is a correct statement. Whereas you take in case of the multiple myeloma, it is characterized by tubular proteinuria. Right, it is characterized by tubular proteinuria. Right, diabetes mellitus and amyloidosis, both of them, these are the etiologies that will be causing nephrotic syndrome. And in nephrotic syndrome, it is the glomerular pathology where you will have glomerular proteinuria. Whereas in case of the multiple myeloma, which is a tubular proteinuria, what are the proteins which are being excreted out? That is Bence-Jones proteins. Okay, that is Benz-Jones proteins that are being excreted out, and these Benz-Jones proteins, they induce the tubular damage, right? They induce the tubular damage. Okay, and in case of the multiple myeloma, there is increased beta 2 microglobulin levels, right? There is increased beta 2 microglobulin levels within the urine, and the presence of the beta 2 microglobulin level in the urine, that is a prognostic indicator of the kidney function, right? And this proteinuria, please remember, whenever you give ACE inhibitors, the proteinuria decreases of diabetic origin, right, or of nephrotic syndrome. So what is the mechanism of action? See, these ACE inhibitors, they cause dilatation of the efferent arterioles. By causing dilatation of the efferent arterioles, the ACE inhibitors, they reduce the intraglomerular pressure. They reduce the intraglomerular pressure. Thereby, there will be reduction in the proteinuria whenever you give the ACE inhibitors. Okay. So, multiple myeloma, it will not cause glomerular proteinuria, it will be tubular proteinuria. And do you know what will be the quantity of the proteinuria in case of multiple myeloma? The quantity of the proteinuria will be 8 to 10 grams per 24 hours. Right, 8 to 10 grams per 24 hours. That will be the quantity of the proteinuria in case of the multiple myeloma, right? So that was the discussion related to the kidney. And if you see the next question, a 35-year patient recalls episodes where he smells pungent odor, becomes sweaty, loses consciousness. His family member says while unconscious he was having facial twitching with lip smacking movements. And what is the diagnosis? The options are the focal seizures, hysteria, atonic seizures, and then there will also be, the other option is myoclonic seizures. So first point, smells pungent odor, that is a clue, right? And loses consciousness, that is another very, very important point. Next, there is lip smacking movements. So this is a case of the focal seizures. And what type of focal seizures? It is complex partial seizures. Okay, in case of complex partial seizures, there will be loss of consciousness. We are using the word complex because there is loss of consciousness. If there is no loss of consciousness, then we call it as the simple partial seizures. And in case of complex partial seizures, there will be automatisms. Now, what will be the automatisms in case of the complex partial seizures? The automatisms that you will have is abnormal chewing movements. The automatisms that you will have is lip smacking. The automatism that you will have is the swallowing movements. The automatism that you will have is the picking movements. So these are the automatisms that you will have in case of the complex partial seizures. And remember, in case of the complex partial seizures, there will be transient impairment of the patient's ability to maintain the normal contact with the environment. So there is loss of consciousness. Okay, and in case of complex partial seizures, the lobe which is being affected is, right, the lobe which is being affected is, this is due to involvement of the temporal lobe. Due to involvement of the temporal lobe, these patients, they will have abnormal olfactory sense. Right, there will be abnormal olfactory sense before the episode. Right, that is what is your whenever the temporal lobe is involved, that will be the manifestations. So this is a case of the focal seizures. And in case of hysteria, you don't have this automatisms, right? And you don't have these abnormal smell sensations. And atonic seizures, what will be the presentation is, in atonic seizures, there will be sudden loss of tone within the skeletal muscles, and these patients, they will have drop attacks. Right, and drug of choice will be valproic acid. And in myoclonic jerks or myoclonic seizures, it is a single group of the muscle fibers which will show the spasm. And in case of the myoclonic seizures, the drug of choice, it is again, the drug of choice, it is the valproic acid. Right, drug of choice is valproic acid. That is what you will observe in case of the myoclonic seizures. Right. Next question. Lennox-Gastaut syndrome is characterized by single seizure type, atypical febrile seizures, good prognosis with adequate control, EEG shows less than 3-head spike and wave discharge. So in case of Lennox-Gastaut, you will have the EEG less than 3 heads spike and wave pattern. Now what is that seizure where you have 3-head spike and wave pattern? 3-head spike and wave pattern that is observed in case of the absence seizures. right? In absence seizures, you have 3-head spike and wave pattern, and it is not single seizure type. Here you will have multiple seizures, right? Multiple seizure types are observed in case of the LGS, that is Lennox-Gastaut syndrome. Now, what will be that multiple seizure type? The multiple seizures include, number 1, the GTCS, generalized tonic-clonic seizures. Number 2, atonic seizures. Number 3, there will be atypical absence seizures, right? Atypical absence seizures. So this will be the multiple seizure types that you have in case of Lennox-Gastaut syndrome. And the second part, so you will have a triad. So first important feature is this, and second part of the triad will be the EEG. So what does the EEG shows? The EEG shows less than 3 spike and wave discharge, right? And that is the second. And third point in case of Lennox-Gastaut syndrome is there will be impaired cognitive function. Right, there will be impaired cognitive function. So this is a triad in case of the Lennox-Gastaut syndrome. So Lennox-Gastaut syndrome, it is multifactorial in nature, right? And this Lennox-Gastaut syndrome is associated with the CNS disease or CNS dysfunction. There will be also developmental abnormality, and Lennox-Gastaut syndrome also has a perinatal hypoxemia or ischemia as one of the precipitating event. So LGS, and the prognosis, good prognosis with adequate control? No. Atypical febrile seizure? No. So it is multi seizure type. What is that multi seizure type? GTCS or atonic or atypical absence. Okay, next question. Now, which drug is suitable for epilepsy related to the brain tumor? Levetiracetam, phenytoin, carbamazepine, then the phenobarbital. So in epilepsy which is caused by the brain tumor, the agent of choice or those drugs that do not induce the hepatic microsomal enzyme system. Okay, now what is that particular drug which will not induce the hepatic microsomal enzyme system? That is levetiracetam. Now what are the other drugs apart from levetiracetam that will not induce the hepatic microsomal enzyme system? Is topiramate, that is the second molecule. Third, lamotrigine. Fourth, valproic acid. Fifth, lacosamide. Right, fifth, lacosamide. So these are the drugs which do not induce the hepatic microsomal enzyme system, and they can be given in epilepsy related to brain tumor. Whereas phenytoin usually given in case of the focal epilepsy as an alternative drug, and carbamazepine, this is the drug of choice in case of the focal epilepsy. Right, this is a drug of choice in case of the focal epilepsy. Next question. Gender specific side effect of the valproate: alopecia, weight loss, PCOD, and as well as the tremor. So now when the question is asked gender specific side effect of valproate, that is PCOD, that is polycystic ovarian syndrome. These are, so menstrual abnormalities and PCOD, these are the side effects of the valproate that are observed in females. Okay, and what will be the most common adverse effect associated with valproate? The most common side effect associated with the valproate will be transient GAT effects, and the transient GAT effects will be in the form of anorexia and as well as vomiting. And these patients who are taking the valproate can also develop CNS side effects, and the CNS side effects include sedation, ataxia, tremors. Right, sedation, ataxia, tremors. So these are the CNS related side effects, and some of the rare complications associated with the valproate will be fulminant hepatitis. Right, fulminant hepatitis. And please remember, this valproate, it is a drug of choice in multiple types of the epilepsy. It's a drug of choice in GTCS. It's a drug of choice in case of the absence seizures of the child age group more than 4 years, because less than 4 years the valproate can cause hepatitis in child. So that is the reason why the valproate is the drug which is given in child of more than 4 years. Okay, next, and third important variety is the atonic seizures. Right, so in atonic epilepsy also valproate is the drug of choice. Then in case of the myoclonic epilepsy, okay, myoclonic epilepsy, so in all these conditions the drug of choice is the valproic acid. In all these conditions the drug of choice is valproic acid. That is very, very important point. And this valproic acid, it will not cause weight loss, it will cause weight gain. Right, and alopecia it is observed, but it is not gender specific side effect. Gender specific side effect will be the polycystic ovarian disease. And not only that, this is also the drug of choice in case of juvenile myoclonic epilepsy. So valproate has a broad spectrum in the treatment of the epilepsy, right? Next question. The following statements are true regarding the epilepsy except Jacksonian epilepsy is a spreading seizure type. Serum levels of prolactin increases dramatically after tonic-clonic seizures. Changes in memory or perception and blackouts are not the features of complex partial seizures. Absent seizures are brief and more frequent without the post-ictal confusion. So the question asked is the except. Okay. So Jacksonian epilepsy. What is Jacksonian epilepsy and where do you observe this? Jacksonian epilepsy, it is the epilepsy that you see in the focal epilepsy, right? And in case of Jacksonian epilepsy, the involuntary movements, they start at the tip of the finger. The involuntary movements, they start at the tip of the finger. And the involuntary movement from the tip of the finger, they gradually progress proximally to the hand, forearm and arm, and following that the involuntary movements will be there throughout the body. That is what is called the Jacksonian epilepsy, and this Jacksonian epilepsy is a feature of the focal epilepsy. Then serum prolactin level. See, the levels of the serum prolactin is very much important to differentiate whether the individual is having a true seizures or whether the individual is having the psychogenic seizures. In true seizures, the prolactin levels are elevated, whereas in psychogenic seizures, the prolactin levels will remain normal. That's a very, very important differentiating feature between psychogenic and as well as the true seizures. Okay, right? And tonic-clonic convulsions, yes, the prolactin levels are elevated. Changes in memory or perception and blackouts are not the features of the complex partial seizures is a wrong statement, right? That is except. In case of complex partial seizures, there will be loss of consciousness, there will be blackouts, there will be memory impairment. Okay, and absent seizures, they are briefer and more frequent without post-ictal confusion. That is a true statement. Now, if you take this absent seizures, the another name for this is also called as petit mal epilepsy, right? It is also called petit mal epilepsy, and this absent seizures, it is very common in children, right? And there will be multiple episodes that will be observed in a day, right? And these episodes will be there for few seconds, 2 to 10 seconds. What will the child present with? The child will present with a staring look, right? Or mild blinking of the eyelids will be there during that particular staring look. And there will be no post-ictal confusion, right? Post-ictal confusion will not be there. And there is no loss of the postural tone, right? There is no loss of postural tone during the episode of the absent seizures. And please remember, these absent seizures, they have the EEG finding as 3 Hz spike and wave pattern. And in case of absent seizures, please remember a very important point. By the time they reach almost 15 to 20 years, the absent seizures, they disappear. And what will be the drug of choice? Drug of choice in case of the absent seizures of age less than 4 years, you need to give 𝗏𝐼, right? Whereas age more than 4 years, right? Whereas age more than 4 years, you need to give the valproic acid. You need to give valproic acid. So this is about the absent seizures or the petit mal epilepsy, right? Next question. A patient presents with history of lip smacking and staring for 3 minutes. Past history of headache for 6 months. He was unaware of the event. The MRI shows a mass in the temporal lobe showing the hyperintensity on T2 weight image. What is the diagnosis? Meningioma, astrocytoma, craniopharyngioma, glioblastoma multiforme. Okay, so the patient is having lip smacking, MRI showing in the temporal lobe hyperintensity. So this is a feature of complex partial seizure secondary to a tumor. And what is that particular tumor having this particular MRI finding causing complex partial seizure? That is astrocytoma. That is astrocytoma. So the clinical features are of those focal seizures with dyscognitive features. There is cognitive impairment, right? And MRI shows the features of brain tumor, and the diagnosis is brain tumor related epilepsy. Brain tumor related epilepsy, right? And what are these particular brain tumors which are related to epilepsy? One is dysembrioblastic neuroepithelial tumor. Dysembrioblastic neuroepithelial tumor, the seizure frequency is almost 100%. Next is ganglioma. Chances of the tumor is almost 80 to 90% in case of the ganglioma, right? Whereas even in astrocytoma, the chances of the tumor is almost 75%. So among the options which has been given to you, the most common is like astrocytoma, because you don't have the option of the ganglioma. You don't have the option of dysembryoblastic neuroepithelial tumor. Next to your astrocytoma, the next most common tumor which will be associated with epilepsy, that will be meningioma. But the percentage is only 29 to 60%. So that is the reason why the answer is the astrocytoma. And not only that, in case of astrocytoma, if you see the MRI finding, low grade astrocytomas, they are typically hyper intense on the T2 weighted images, right? They are hyper intense on the T2 weighted images, whereas on T1 weighted images, they are most low grade astrocytomas in T1 weighted images, and they are hypo intense. T1 weighted images are hypo intense, whereas T2 weighted images are hyper intense related to the astrocytoma, right? And next question. All are used in early generalized convulsive status epilepticus treatment except phenobarbital, fosphenytoin, lorazepam, and then valproate. So if you take the status epilepticus, what is the definition of the status epilepticus? Like, see, one episode of the seizure should be there for at least 5 minutes, right? Or there should be repeated episodes of seizures, right? There should be repeated episodes of seizures, and in between these episodes, the individual should be in a state of loss of consciousness. And all these episodes, they should be lasting for nearly around 15 to 30 minutes. Right? All these episodes, they should be lasting for around 15 to 30 minutes. Okay? And where there should be impairment of consciousness between the episodes. And what is the drug of choice in case of the epilepsy? The drug of choice in case of the epilepsy is lorazepam. Lorazepam is the drug what we give in the early stages. Right? So either lorazepam or midazolam or clonazepam are the drugs that can be given, right? And after giving 2 to 3 doses of your lorazepam, if the epilepsy or if the seizure attacks are not reducing, then the drugs that can be given is phenytoin can be given, and as well as valproate also can be given. Whereas if you take phenobarbital, the answer here is phenobarbital. Phenobarbital, we don't give it in case of early refractory status epilepticus, right? Whereas in late refractory status epilepticus, we give this phenobarbital. And apart from phenobarbital, the other drug that can be given is, right, the other drug that can be given is thiopentone. The other drug that is given is thiopentone, right? So this is about the status epilepticus treatment. As such, the drug of choice is lorazepam, and the dosage of lorazepam is 0.1 to 0.4 milligram per kg body weight. Right? Now, coming to the next question. Drug of choice of GTCS in pregnancy: lamotrigine, carbamazepine, levetiracetam, valproate. So in pregnancy, the preferable anti-epileptic drug is levetiracetam. So actually previously, like, we were giving lamotrigine, but further studies have shown that the lamotrigine, right, the risk with lamotrigine, it is comparable to the risk of neural tube defects with ordinary population. So there can be minimal chances of neural tube defects with the lamotrigine. Okay, but levetiracetam, it is the drug of choice in case of GTCS in pregnancy. That's a very, very important point, right? Whereas carbamazepine, this is a drug of choice in case of the focal epilepsy. Valproic acid, I have already said you, it is the broad spectrum anti-epileptic drug. It's a broad spectrum anti-epileptic drug. Okay, so one last question and then we'll wind up this. A 72-year-old man with normal renal function presents with new onset focal seizures. Which of the following is the best drug to manage the patient? Sodium valproate, carbamazepine, levetiracetam, and as well as the and then pregabalin. So focal seizures, just now I was discussing, what is the drug of choice? That is carbamazepine, and that too the patient is having the normal renal function, wherein the carbamazepine can be given safely, right? And suppose if the patient does not respond to carbamazepine, you can also give oxcarbamazepine. And what are the other drugs that can be given in case of the focal epilepsy? The other drugs that can be given in focal epilepsy is lamotrigine, and the other drug that can be given in case of the focal epilepsy is levetiracetam. Okay, so lamotrigine, levetiracetam, carbamazepine, and one more, that is phenytoin. That is phenytoin. Okay, so these are the drugs that are given in case of the focal epilepsy, right? So one more question that we have is about the hypsarthemia. Hypsarthemia on EEG is seen in infantile tremor syndrome, petit mal epilepsy, rhodandic epilepsy, infantile spasm. So hypsarthemias are observed in case of the infantile spasm. Okay, so what are these hypsarthemias? Hypsarthemias are high amplitude waves, right? Hypsarthemias are high amplitude waves and spikes are present. Okay, high amplitude waves and spikes are present, and they randomly appear with no topographic distribution. They randomly appear with no topographical distribution. They have high amplitude, waves and spikes are present. Okay, and in case of infantile spasm, there is highly disorganized brain activity. And what is the drug of choice in case of infantile spasm? That is ACTH. And if the infantile spasm is associated with tuberous sclerosis, then the drug of choice will be vigabatrin. Right? Then the drug of choice is vigabatrin. Okay. One more question, that is PLED, that is periodic lateralized epileptiform discharge. So PLED showing on the EEG is seen in herpes simplex encephalitis, mesial temporal sclerosis, subacute sclerosing panencephalitis, variant Creutzfeldt-Jakob disease. So please remember, the presence of PLED, it is suggestive of herpes simplex encephalitis. Suggestive of herpes simplex encephalitis, right? And in case of Creutzfeldt-Jakob disease, the EEG shows non-specific findings. What is that non-specific findings? Such as FIRDA, such as diffuse slowing and frontal rhythmic delta activity, right? Diffuse slowing and frontal rhythmic delta activity in early stages. That is what you observe in case of the Creutzfeldt-Jakob disease. Whereas the periodic lateralized epileptiform discharge, it is a feature of the herpes simplex encephalitis, right? So that is about the PLED, right? And two more questions. How much CSF can be tapped in normal pressure hydrocephalus to determine the likelihood of response to the CSF shunting? 10 to 20 ml, 20 to 40 ml, 20 to 60 ml, 40 to 60 ml, 60 to 80 ml. Now for determining the efficacy of CSF shunting in normal pressure hydrocephalus, a tap test is done. What is that particular tap test? And this particular tap test, it is called as the Fisher test, right? It is called Fisher test is being done, right? And you know what is the best tolerated? The best tolerated, it is a tap of 20 to 40 ml through lumbar puncture, right? 20 to 40 ml through lumbar puncture, okay, with recording of opening and the closing pressures. With recording of opening and the closing pressures. Okay, so the answer here is 20 to 40 ml. And what are the other methods used which are more invasive and might be refused by the patients are multiple lumbar punctures that should be done over 3 to 5 days, insertion of continuous lumbar puncture CSF drain, and radionuclide cisternogram. So these are the other methods that can be tried. Okay, so yes, so these are the important questions that you need to know before you go into the exam. So thank you very much. Thank you for listening to me, and all the best.